Hello.
12 o'clock.
Good afternoon to you. My name is JM. I am the Faith and Justice Organizer here at Equality Ohio, and I just want to welcome you to our webinar today. Stigma doesn't have to be our conversation. It didn't arrive yesterday, today, and it won't go away tomorrow. But it requires some engagement. And today we're going to have a conversation with the United Church of Christ around the people living with HIV stigma index, as well as a conversation that centers the lived experience of people living with HIV. Now, I want to let you know a little about what OHMM does. OHMM is the Ohio Health Modernization Movement, and we work to modernize the criminal code of HIV. And next month, we're going to have a very interesting webinar giving us insight on how we can better serve our next generation in regards to HIV awareness and stigma. So be on the lookout for that information. It's going to come out, and we'll share it the same way and to your emails when you sign up. Also, at the end of today, there will be an evaluation and survey. We encourage you to please let us know how we're doing. Let us know what we can do to help. And also, there's places where you can offer suggestions for future webinars so that we can better serve you as well. So I want to introduce our discussion facilitators today. You're in for a treat. First, I have the Reverend Michael Schudemeyer, which is, he serves as minister and team lead of the Health and Wholeness Advocacy Team in the national offices of the United Church of Christ, based in Cleveland, Ohio. He leads a team that provides leadership in the U.S. and globally on HIV, comprehensive sexuality education, sexual orientation and gender identity, disabilities, mental health, overdose and drug use, scouting, and wellness ministries. He also serves as the executive director of the United Church of Christ HIV and AIDS Network, also known as UCAN. We also have August Lee Butler, originally from Albany, New York, a servant leader with 20 years experience as a progressive manager, community organizer, and advocate. Mr. Butler brings a wealth of expertise in human rights, policy analysis, health and human services programs designed to improve human conditions and intergroup relations in the community, especially for those underserved, impoverished, and marginalized. He is also the national coordinator for the Framework of Dialogue US, which we will be discussing today. Welcome to our August panelists, and I will yield the floor to you.
Great. Thank you, JM. And hello, everyone. It's good to be with you today. Hello, Arthur. It's good to join you as a part of the conversation today. I want to get started just to give Arthur and I the opportunity to say a little bit about why we're passionate about working to dismantle and reduce and eliminate stigma discrimination. I became an ordained minister in 1984. I'm that old. And I started my ministry in Southern California in the Inland Empire, San Bernardino, Riverside, you know that area at all. And this is when HIV was on the scene. Things were happening and people were becoming ill. And there was an awful lot of stigma that was going around. And I was serving a United Church of Christ congregation in San Bernardino. And I remember getting a call from the pastor of the Metropolitan Community Church, and he was trying to get a group of faith leaders together so that we could provide some support to people who are living with HIV in the Inland Empire. What he was seeing is that a lot of people were being isolated at what was at that time AIDS wards and hospitals. They weren't getting visited by their family, and they weren't getting visited by their friends and loved ones, even at that time. It was a challenging situation. And so we worked together and created the Interfaith Council of the Inland Empire and began to develop some resources, began to have conversations with other faith leaders in the community to see what we could do. One, to try to lower some of the stigma, but also to make sure that people were getting the pastoral support that they needed. It just became so incredibly clear that people's attitudes were just as virulent in causing suffering and death in the epidemic as the virus was itself. And so for a very long time, it's been a passion of mine to be concerned about how we not only work with the science, which is so incredibly important, but also how it is that we work at the human relationships and the way in which we offer compassion and care to people who are not only living with HIV, but who are also personally affected by it. And so having been engaged in that response, I've witnessed a lot of the suffering and death, and know that it's really past time that we end stigma and discrimination in relationship to HIV in this epidemic. If you've had a look at any of the gap reports that UNAIDS has presented over the last 6-8 years, you'll know that if you just do a little word search on the word stigma, and you'll see it pop up 400 or 500 times. And there are only, I guess there are about 400 or 500 pages to some of those reports. It's on every page. And so we know that it is one of the key barriers to being able to end this epidemic. And I know that the attitudes that people bring to this epidemic oftentimes are influenced by their faith. And faith hasn't always done a good job of responding. Oftentimes, the messages that have come from faith leaders, particularly those that get amplified in the media, are not positive voices, they're negative voices. And we also know that from the pulpit or from other lecterns of faith institution, houses of worship, the people who are living with HIV and others who are affected don't always hear the most positive messages. The kinds of messages they hear are not affirming for them. And so they don't always feel that the faith community is one that is welcoming of them. We know that people who are living with HIV sometimes feel isolated from their faith communities, and they will avoid going to their faith communities. So as a faith leader, I wanted to try to motivate faith to fulfill its role in trying to address these issues to reduce and eliminate stigma. And one of the places where we've worked on this is around the framework for dialogue. And we'll say more about that in a minute, but I'm going to pause. Now you know a little bit about where my passion comes from. And I want to turn it over to Arthur and let him share a little bit about that for himself.
Yeah, thank you, Mike, and welcome everybody. As JM said, and as Michael has directed your focus, I'm Arthur Butler. I am here in beautiful upstate New York. I am part of the team with the United Church of Christ, and I'm the national coordinator for the Framework for Dialogue. And like Mike, I thought that, and I consider myself to be a servant leader as well. And I came back to the upstate region after going away for a while after college. And I found myself working as a case manager at a local AIDS service organization. And while I was in that position as a case manager, I noticed some unique differences around the people who were HIV positive, who looked like me, versus those who did not look like me. And so I started to advocate for my clients as they came in. And when denied services, I would ask them to bring their support network into the office, and I would have their supervisor sit in front of the many supports that the person had and explain why they weren't able to receive $20 in food vouchers. But I knew that it wasn't enough just to do that. I knew that there were some serious gaps in the service model in the capital region. And so to address that, I gathered a group of 40 individuals from across the capital region to a meeting, and we started to have conversations. From that conversations, we formed an AIDS service organization solely dedicated to working with underserved populations, folks who had been marginalized, overlooked, disenfranchised, every issue that you can imagine. Those were the folks that we started to provide services for. when that ended, I had a unique opportunity to work with United Church of Christ on the framework for dialogue. I just believe that in order for us to eliminate stigma, that the eliminating of stigma is vital to stopping the spread of HIV and ending HIV-related deaths. So, you know, I'm passionate on many reasons, or many levels, but I believe that I am part of a community, and being part of a community, I must support that community. I'm the youngest of 17 kids. I tell this story a lot. And so I learned how to advocate being the youngest of 17 kids, but also it was important that my parents taught us that, that we shared more than we had differences then. And so when someone passed away on the street that I lived, we would go around and take collections up and make sure that the community provided flowers and support. And so it's been that passion, it's been that which has been instilled in me that works now with the framework for dialogue to bring the faith community together with the communities that are being underserved, that are marginalized. And we're just asking that they share and talk about love, faith, compassion, but having the conversation is the most important thing. So I know we'll get into more of the dynamics around the framework, what stigma is. So I'll pass the baton back over to Reverend Mike.
Thanks, Arthur. Yeah. So, and I'm sure many of you can share stories about passions that you have and the way in which stigma has impacted your lives and the lives of people that you know and love and care about. And so it is important work that we're engaged in. The framework for dialogue came in existence about 10 years or so ago. And it was something that came out of another process called the Stigma Index. That's a tool that is used to measure HIV-related stigma. I know it's been talked about, I think in the last webinar that was hosted by OHMM, and we're going to say a little bit more about it in a few minutes as well. And the framework for dialogue actually uses the report that comes from the Stigma Index to gather faith leaders and people living with HIV and technical partners, some of the AIDS service organizations and such, to have a dialogue about that evidence. And then hopefully the idea is for that dialogue to lead to joint actions. Those actions hopefully strengthen the engagement of faith in the HIV response, and in particular, work to dismantle, reduce, and eliminate HIV-related stigma and discrimination. I want to, before we get too much further into the framework for dialogue, I want to just kind of lay out a little bit of what we're talking about when we talk about stigma. I know there are a couple of models out there that use kind of some, like as many as 7 indicators about what stigma is. And I want to share something that talks about what I think are the 4 main types of stigma. And I'm going to share my screen as I do this because I have a slide. So if everybody can see that slide. Let's see. There we go. All right. So one of the first types of stigma is internal stigma. And that's the kind of stigma in which a person turns harmful judgments on themselves. And so they've heard these messages from others along the way, and simply because maybe they have received a positive diagnosis that they are living with HIV, just for that very one, they turn the stigma on themselves and feel that just for that very fact, they are a poor or a bad person. They turn the harmful judgment on themselves. Another example is the anticipated stigma. And so that's where someone perceives or fears that they're going to experience mistreatment and discrimination. So a person's just received or is experiencing symptoms that they might have HIV, but they're afraid to go get a test because they're afraid of what people might think of them if they're seen getting tested for HIV, right? It becomes a barrier to for people to get tested. And we know how important testing is to knowing your status so that you can be linked to the kind of treatment and care with effective antiretroviral medications that can bring your viral load to undetectable. And that when someone is undetectable, they don't transmit the virus. We know how important that is in the process of ending the epidemic. Then there's the external enacted type of stigma, and that's where you actually experience the judgment, the mistreatment, or the discrimination that someone might. It might be the way in which someone treats you whenever you are in a healthcare setting. Anyway, that's the actual enacted stigma that that a person might experience. And then there is also structural stigma. Those are the laws, policies, or regulations that have a discriminatory or stigmatizing effect on people. And so, for example, in Ohio, the way in which the criminal code is currently written is in a way that criminalizes HIV. And we know that when HIV is criminalized, we don't see the kind of health outcomes that we would like to. We see people are not getting tested. We see that people may not be able to be linked to the kind of care and treatment, or it becomes difficult to sustain people in treatment and care. Because simply knowing your status can put you in a vulnerable place where you actually might be accused of a crime or convicted of a felony. And so that's one of the reasons why the United Church of Christ has joined the Ohio modernization movement in order to help reduce that kind of stigma that people would experience, and also the injustice of being accused of a crime. HIV is not a crime, it's a disease, and we should work at it from that perspective. Arthur's going to talk now about the stigma index itself. So I'm going to pass it back to Arthur. Just like a tennis tournament, we're passing the ball back and forth to each other.
Thanks, Mike. And I invite you to also pay attention to some of the links that are being put up in the chat. One is the stigma index, and I know that the folks at OHM will be putting some additional information up. So look at those things. But as Mike had said, that the people living with HIV stigma index is a standardized tool to gather evidence on how stigma and discrimination impacts the lives of people living with HIV. The PLHIV stigma index was developed to be used by people living with HIV and was created to reflect and support the greater involvement of people living with HIV. So what the stigma index does is that in the areas that we're working in, and we work in 3 primary target states, one being Detroit, in the city of Detroit, Greater Detroit, New Jersey, Baton Rouge, and also New Orleans. And so the stigma index sent a group of peers out to conduct surveys and to collect the data from these surveys so that they could come up with a set of priorities for each area that they're focusing on. So it's not a one-stop shop where one thing that's in Detroit is similar. It might be, but may not be in Baton Rouge. In Detroit, for instance, the stigma index, one of the priority areas was around criminalization and criminalizations of sex workers and folks who were positive with HIV. So when we can look at the data then we can have the conversations around the data and bring insight and a voice to the data and real perspective so that the faith community can then look at and come up with conversations, and from the work that they do at the table, those joint actions. But that's further down the line, but really to look at the impact and how stigma and the characteristics of stigma really impacts the community. As I said earlier, it's very vital to stopping the spread. How we look at stigma, how we measure stigma, how we talk about and address stigma is vital to stopping the spread of HIV and also eliminating and ending HIV-related deaths. You know, what the Stigma Index does and the work that we do at the framework is really in alignment with the ending the HIV epidemic by 2030. And so we focus our attentions after the evidence has been collected, and then that's when we go to work. So it's a standardized tool, but in that standardized tool, we get to tweak and also tailor it to the communities that we're going into. Thanks.
Thank you, Arthur. Yeah. So I saw someone in the Q&A ask a question which helps to lead into the next part of what we're going to talk about, which is related to the framework for dialogue. And that is around how does the church address stigma and persecution from the congregation with regard to HIV and religious beliefs, drug use, same-gender loving, and I'm not sure what the last one is, morals, I guess, or morals, I guess that's the question. And so I'm not going to answer that quite directly just yet, but hopefully through what we're going to share next, we'll get at some of that. Because faith is not a monolith. There's a lot of different perspectives in the faith, and we know that there are progressive houses of worship, and there are more conservative and very strict houses of worship. And there are lots of houses of worship that are somewhere in between. So how can we move houses of worship to be more affirming, more accepting, more helpful, more supportive, more caring and compassionate? And one of the ways in which we feel that that can happen is when faith leaders, one, get in the room with each other, secondly, create a space when they're also in the room with people who are living with HIV, and they can bring them around a table in which people treat each other as equals. And they also have people who have expertise in a field in the room, in this case, the field of HIV and HIV response. And they're able then to put something on the table that has some neutrality about it. And so that's what the Stigma Index report does. It's something that's a little bit more neutral, right? It's evidence. This is what the data shows. So let's just look what the data is telling us about what people are experiencing where stigma is concerned. And so in the framework for dialogue, we bring together a core team of people who help to look at the Stigma Index and prepare a report for a dialogue from a faith lens. What does the Stigma Index report say about how people experience their faith community, their spirituality? What has been a barrier for them with that? And what has provided entree that's been helpful to them in that? And where have people experienced faith communities that are affirming, and what are their health outcomes? How's that related to health outcomes? And those are the kinds of things we want to place on the table so that people can have a conversation about that. The Stigma Index isn't the only evidence that we place on the table. And in some places, it's not the only place where stigma has been studied. And so we look for other reports and other information that we can share. We share information about trauma and how people experience that, and so that people can talk about, well, what does trauma-informed care look like? And we feel when we can create a safe space where people can actually share their stories, be themselves, even challenge each other, that people are able to build relationships of trust, and they're able then to work within those relationships towards positive outcomes in their community, working together for positive outcomes in their community, particularly where HIV is concerned. And so it's evidence, it's dialogue, and action. We believe faith leaders are important because faith leaders can often be thought leaders in the community. They have a large network of constituencies that they can relate to, and they're able to help disseminate information, correct information, and right information. And we feel that being in relationship with other people can sometimes have aha moments. I didn't realize when I put it this way that this is what you experience. And so they can find language that's actually more helpful to talk about people living with AIDS rather than AIDS victims or other kinds of language that can be stigmatizing for folks. The framework for dialogue is built on 8 principles. And I'm going to share my screen again and kind of bop through those principles with you. So one of the principles is that in the framework for dialogue, we strive, okay, sometimes it's a little bit delayed and advancing. There we go. Is that it's country owned. Originally, the framework for dialogue was created as a country level tool. We are working with it in the United States as more of a local and regional tool because we have so many cultures across the country. And so in this case, the dialogue is driven by local partners and local priorities in the US. That it's evidence-based, right? I've been talking about that all along. All actions of dialogue are based on evidence, both qualitative and quantitative. That it's people-centered. The dialogue begins with the experience of people living with HIV and practicing their faith and the impact of the work of faith institutions on their lives, and not vice versa. In other words, this is not a dialogue in which faith leaders come together and tell people living with HIV what faith communities have been doing to respond to HIV. That's not what this tool is about. It's about creating a space in which people can hear the experiences of people living with HIV, look at the evidence around that, and figure out what they want to do together to strengthen the response of faith communities in HIV, and also to work at how they can dismantle and reduce and eliminate stigma discrimination together. It's based on the principle of do no harm, that all participants in the dialogue process agree to do no harm, especially in the areas of disagreement. Participants respect the confidentiality and identity of participants in the dialogue. It involves equal and meaningful participation. All the stakeholders enter the dialogue as equal partners, allow full participation, involvement, and decision-making throughout the dialogue, and emerging joint actions. It's meaningful, not tokenistic participation from people living with HIV throughout. And it focuses on innovation. New partnerships are formed and out-of-the-box thinking and solutions are encouraged. It's action-oriented. The focus of the process is to move beyond dialogue to collaborative and constructive actions. And it's grounded in safe space. The methodology and facilitation of the dialogue aims to create a space where all entering the dialogue can be sure that they will not meet discrimination or judgment. But let's be real, we also know that no space is 100% safe. And so it is an aspirational goal. Safe space is always that. There's never any way to avoid that. Because as JM mentioned at the beginning, stigma didn't just show up yesterday. It's been around for a long time. It's not going away today or tomorrow. It's going to go away because we take the time day in and day out over the long haul to keep chipping away at it. And so that's what the framework for dialogue also seeks to do. It's not one dialogue meeting, it's a dialogue process. And so one of the initial goals is to kind of identify and set up what is that mechanism that's going to enable us to stick with this over the long haul. And what we also believe is that that's something that can be particularly effective in working at the criminalization of HIV, because that takes a lot of relationship building as well to help people understand how the criminal code works, how it is affecting people living with HIV, and what needs to be done to modernize the code so that we can both respect what the science says, and also to have a criminal code that doesn't do the injustice of creating more stigma and preventing people from getting the care, treatment, and support that they need. All right. And
Reverend?
yes.
Hi. So there's a question that just came up, and I wonder if you can talk about it real quick before we move into the next segment. The question was, with the current treatment of the antiretrovirus medications, there is no risk of transmission of HIV to another person if they remain on the regimen and they are undetectable. Um, how does the church provide this information to the public?
Again, I just want to emphasize again that the church is not monolithic. What we hope that churches do is that they share the information. And so the framework for dialogue is one of the ways in which people become familiar and understand what U equals U means, right? That undetectable equals untransmittable. And so we want to work at helping people to get the right information and to be able to share that. And we know that when local churches or other houses of worship actually provide accurate information where people have access to it in that house of worship, that's one of the things that people can do to begin to lower the level of stigma. And for every degree that we lower stigma discrimination, it means that more people get tested, more people get linked to care, more people are sustained in that care, more people get their HIV viral loads to undetectable levels, and that means more people are not transmitting the virus. So it's a really key piece of that thing. Yeah, I hope that helped to answer that question. I see there's another question. How can you speak to how you ensure tokenization doesn't happen? That's a very much important question, but let me throw that to Arthur, because I know, Arthur, that is something that we work with the local core coordinators and teams that are working on that, is to make sure that that does not happen. So you want to talk about how we do that in the framework?
Mike, can you just repeat that question? You kind of went out on me. Just
okay. Can you speak to how you ensure tokenization does not happen?
Yeah. So, Mike was talking about how important it is for our faith communities to really provide an avenue of information to the constituents, and to also be about contributing. And so looking at how they're contributing. And so one of the things that we, in tailoring the framework for dialogue to the different areas of the US that we have worked with, is really to hear those at the table and to just be open to the discussion around the many ways in which information can come out, that it's not by providing information, since most of our faith leaders will talk about and use scripture that will say that our people perish for a lack of knowledge. So we want to empower them to also talk about how to have that knowledge, how to be equipped to deal with the things that the community are facing with, that comes in through the doors of their places of worship, to hear the voices of those people and to give the information as it is. So we work really with those national coordinators, the regional coordinators, to address those issues by, whether it's through surveying, through having conversations one-on-one with faith and religious leaders, and to talk about their concerns, and then to give some different perspectives of how they can address or have conversations around that, so that it fosters an environment of equality where people are at the table that have an equal part in the contribution to dismantling stigma and also eliminating HIV-related deaths caused by stigma. So I hope that answers some of your question, some of that question. But again, it's not a one-stop shop. It really is getting in and working with the community to hear the voices of the community.
Right. And in the stage of of getting the framework for dialogue going, we do pay careful attention to make sure that a variety of networks of people living with HIV are represented at the table, just as we try to make sure that there's a variety of faith leaders who are at the table. That's making sure that voices are present at the table can help to ensure that there's not tokenism as well. Another question is, to my experience and understanding, the church is not or does not share this information, and I think that's generally true. And the framework for dialogue is trying to overcome that by creating a space where people can talk about what would be helpful, and that some of the actions that can come out of the framework for dialogue can create tools for houses of worship to use to be able to share information about HIV with their congregations and in their community. I think the church and houses of worship could be a wonderful place where people can receive accurate information about that. But we recognize, and one of the reasons we're engaged in this process is that faith communities need to be more engaged in this response, and they need to be a place, a vector where people can get good information about that. And but it's not an easy process to run and to implement. Stigma is present in the process throughout, and we encounter it. And I know, Arthur, you've had a variety of experiences in trying to work with groups, particularly in the Detroit Metro and the New Orleans and Baton Rouge areas in implementing that. So maybe ask you to share a little bit of some of the lessons you learned and encountered as you've worked at implementing the framework for dialogue.
Yeah, and thanks. It's important that I believe that we hear what is being said. And so I know that, like, when we went to Detroit, it really was around a relationship building. On my first meeting to Detroit, there were some concerns from those who came to that first meeting around what if we were going to be present and if we were going to be there, or was this just another incentive or another instance where someone comes in and gets information and doesn't put anything back into the community. So really it was around, it's always been around building relationships and how to build those relationships. We build them by really listening to our folks on the community level. So in Detroit, we showed up, we tailored the framework around some of the thoughts that they had, some of what they thought might work best. So it wasn't us coming in, it wasn't United Church of Christ coming in as the expert. We really came in as a helper, to help in dismantling stigma. And so we worked with the faith communities, challenges with our faith communities, because some of the clergy at the table said that the stigma for them to talk about things around HIV prevention, how it lined up with what they were teaching from a biblical standpoint, was to really, again, to get folks to talk more about the love, care, and compassion, that we weren't trying to go in and have a sexual education class or what to do, how to put condoms on, but really to open the doors so that if it was uncomfortable for our faith and religious leaders, that they could partner with other entities within their region. So we worked closely with the Department of Health. We worked closely with agencies in Detroit and Baton Rouge that provided HIV direct services. We worked with folks who had loved ones who were impacted or affected by and infected by HIV, and brought those real stories to the table. So in Baton Rouge, in Baton Rouge and New Orleans, is in the same state, very different in how they approach the framework and how they approach HIV. So what we had to do in those two areas were come up with things. So we listened to pastors again, and we listened to faith leaders to see what their barriers were, what their concerns were. And we then tailored the outreach around their concerns. So if they say, well, I can't talk about this from my pulpit. So the question is, if you can't talk about it because you're afraid to be stigmatized, one, imagine the person who is in the congregation who is feeling the same stigma and the same pressure about sharing with their faith leader about being HIV positive. So maybe you might want to have the expert, the person who's living with, talk about their experiences so people can see the experience versus the person or the lifestyle or the choice, or, you know, take away the judgment. So really some of the best practices that I say the very best practice is really having an ear to listen to what the community is saying. The framework for dialogue helps in that process so that we can gather the information the same way we're gathering the data. The voices are as important as the stats that come in. So really we looked at how to do those things in those three regions. We're looking at going other places, and we know already that we approach each state that we go in, each region that we go in very differently. The framework gives us just that, a framework. But what we do within that framework, how creative we are, how creative we can be, how open are we, and willing, and the willingness and the honesty around being about what it is that we want to do. And if we want to make a difference, if we want to make a change, well, here are some ways that we can do that.
Yeah, thank you, Arthur. And the like one of the primary principles of the framework is working with the local regional folks, right? So that's where we always have to begin, and that means that every implementation of the framework for dialogue is a little bit different because we have to respond to the needs of the local regional folks who are engaged in the process. I think one also the key learnings that we've had is that in other places in the world where the framework for dialogue has been done, it's been initiated by a group of faith leaders, so an ecumenical body or some kind of faith group that's already together, and they've taken the initiative. In this case, the United Church of Christ AIDS Network is the implementing body, but we are going to Detroit and saying, here's the framework for dialogue. Are you interested? And so we're cultivating these relationships, and there's frequently, while there may already be an ecumenical or interfaith body that's already present there, we have to cultivate a relationship with them to try to help them become involved in the dialogue and to see if it's something for them, if it's something they want to do. Places where we've gone so far, people have enthusiastically embraced it. But there have been some challenges in terms of trying to get people together and around the table, particularly among some of the faith leaders. And we're learning that we have to pay a lot more attention to those relationships at the very beginning in order to get started. And so that's something that we're very much in tune with. And this has all been very important learnings for us because we're kind of what we feel is in the pilot stage of implementing the framework for dialogue in the US. And what's happening now is that we are partnered with the US People Living with HIV Caucus to develop a toolkit that will be a toolkit for the Stigma Index in the US, as well as that will integrate the implementation of the framework for dialogue as a part of that toolkit. And we're hoping to be able to begin rolling that out maybe later this year or early 2022. And that will be then a place where we'll have the opportunity to invite people to become involved in working with that toolkit and hopefully be able to begin to take this process more nationwide in the US, so more and more communities are able to have an intervention that they can work on in their local communities that work with faith communities, strengthen their response, and help them to reduce and eliminate stigma and discrimination. So I think I hope I just answered the question that somebody asked about how to become part of sharing info with the Stigma Index. And so I think that that's something that's going to come. And so we'll look forward to staying in touch and letting folks know how that's going down the road. So I think that we're ready to move towards the Q&A part of the discussion.
Excellent. Thank you so much to everyone here. This has been a very robust conversation, and I'm excited to see what's next. So we have a couple of comments in the chat. So I want to raise these up for possible questions as well. Robert Watkins says, stigma only exists because the dialogue is presented. For example, the term risky sex or safe sex. All sex is risky. A new dialogue would be, instead of saying safe sex or risky sex, use transmission of an STI. Also infected by HIV is stigmatizing. Another way to express this would be transmission of HIV, not infected by. Words we say are important. What's the response to that? Because as preachers and servant leaders, I know you are very integral with word placing. So talk about how we can, if you would, how we can educate our faith leaders into how to use more graceful words.
Yes, words, deeds, and actions, right? And the impact of those words. And, you know, I think that sometimes being in the forum that I'm in and having worked so long, that you sometimes just pick up the lingo that is part of the documents that you have read, the reports that you have read, how it's worded in the healthy people's profile, those types of things, writing grants, all of that kinds of stuff. But really, as we talked about, as what we do in the framework is really allows room for people to find a way to communicate. And so how we communicate and how that communication can be most effective, and to really just challenge each other in a respectful way around how we talk about. I know with our faith communities, one of the things, which I'm glad we're back to this through this question, was that we really work hard at letting our faith communities know that this isn't a format for them to come and be attacked or to be told what they're not doing. We could spend all day talking about what we're not doing and what our differences are, but what can we do together? How can we address this together? How can we dismantle stigma together? We're not going to change everybody's mind, but if we make an atmosphere which is open, and we create an atmosphere where people become willing to have the conversation, then I dare say that change is not far behind that. So, yeah, I'll turn it over to Mike.
Yeah, I agree. I think it's really doable that we can help people be better with their language. There are already existing a number of language guides, not just around HIV, but around gender, around transgender, around a whole host around disabilities and mental health. And so the framework for dialogue becomes a place where people can share some of these guides and have a conversation about and talk about, you know, why it is that using certain kinds of language is helpful and using other kinds of language is not. And even though that might not be a particular campaign thing that someone develops, but it can be helpful to folks so that clergy colleagues can actually work with each other to say, why don't you try this? This might be more helpful language to use. So helping people be in the room with each other and try to improve what they're doing. And again, like I said, every little bit that we can lower the experience of stigma that people have just opens the door to more positive outcomes.
And JM, can I just add that sometimes it's not about folks being disrespectful. Sometimes folks just really don't know. And so developing strategies in Baton Rouge and New Orleans, we looked at each segment of the faith community, from seniors to mid-age, to young pastors, to large denominations, to storefront churches, and then how to outreach to each of those persons. One of the older pastors may not know. So when we see, even in our choices of pronouns, they may say, well, this is just getting too hard for me. We don't want them to walk away because it's too hard. We want them to stay in the process and see that, all right, there's just another way of saying things and being present. You may never say it. It's not that you're being disrespectful. It may be that you just don't want to seem as if the people who are looking to you as all knowing, that you really just don't know. So getting folks to say, hey, I don't know,
That is a great thing. The I don't know has saved so many conversations, because it brings a spirit of grace, right? Because you realize we're all trying to work at this together. Another statement here, and then we have a question as we come too close to the end of time, but we have a couple more moments. Statement: non-judgment is the most important part of dialogue. Judging a person is against biblical rules, laws. We as people are not supposed to judge anyone. I'm not going to touch that one at all. Because I am an INFJ, so there's the judging that is part of the personality of me, and I look at judging as a different stance. But I'll yield the floor to you to have a comment on that statement really quick.
I remember, I think it was at the UN high-level meeting on HIV in 2016. Bishop Yvette Flunder spoke at the Interfaith Prayer Breakfast, and in her remarks, she talked about the importance, and there were heads of state in the room, the importance of offering healthcare without judgment. That health is a right, everyone should get it, no one should be judged, and so in that context, it's very important that we take a public health perspective in our work on HIV. And if we take a public health perspective, then we need to also recognize we need to work and understand and have conversations so that we can deepen our understanding of the behaviors that we engage in that are stigmatizing. So much of this is enculturated in us. So much of it's internalized, and we just do it because that's the way we do things. And we know that we can't continue to do that if we're going to be serious about reducing and eliminating stigma. And if we're not serious about reducing and eliminating stigma, we're not serious about ending the epidemic. And we need to be serious about ending the epidemic and the suffering and death that it causes. So it's really critically important work.
That was an amazing response to that question. This is why you've been ordained almost 40 years here. So we appreciate your wisdom here. And we have two more comments and then a final question. And then I want to pose a question to you about what do we do next? Mm-hmm. So Robert Watkins, he's been very involved. Thank you so much for asking those hard and pointed questions. We do appreciate it. Response was excellent. Thanks for clarification on language. Leading by example, not status quo. This mission would be out of the box thinking. So thank you for that comment. We do appreciate it. We have, Darren has a comment as well and a question. I don't know if we'll be able to get to this because I think that's a larger question, but I'll put it out on the floor. And then I want to really talk about this, Julie, the question from Julie Patterson. But Darren asks, isn't judging more about making biblical assessments of a particular issue rather than condemning? I think this is a very challenging area of pastoring.
So people oftentimes present a biblical rationale to the judgments that they make. But even if you were to be able to deconstruct that rationale, at the end of the conversation, people will still hold the value that is judging. And that's because it's not really about the biblical value. It's about what I am comfortable with. And we know that one of the ways in which you get to the heart of what people are comfortable with is if you can create a safe space in which people can enter into a relationship with each other. When they see that they're in a relationship with another human being that they begin to care about, it's more difficult for them to continue to hold the judging values. And it's why we talk about changing hearts and minds, not just changing minds. And so that's what the framework really tries to do in bringing the faith leaders together with people who are living with HIV and creating a safe space so that those relationships can form and people can be transformed by them.
Amen. Amen. So Julie Patterson has a question, and we're going to end on this question from our audience. But if you have any further questions, feel free to reach out to us, and we'll definitely get those questions to the panelists. We would ask that you do not reach out to the panelists personally with those questions unless through an authorized email and not on social media. But for the final question before what can we do next for you two, will the FFD help communities to assess the progress in HIV-related stigma over time? For example, do people involved do a before and after snapshot of stigma in their local areas by using the Stigma Index?
I can say that we're working at developing those tools. We've entered into a partnership with Baldwin Wallace University to have a research component to the framework for dialogue. And we do pre and post surveys with people who participate in that. The framework for dialogue in Louisiana is funded by the Compass Initiative through a transformative grant. We're currently beyond that. Grant ended end of December, and we've applied for another one. We're trying to figure out if we got it or not. We should know any day. But again, there is a research partner there with Emory University as well, and with the Southern AIDS Coalition. And so we're very much interested in trying to learn and actually develop evidence. And we are building into the toolkit some of those assessment tools so that people can do that pre and post work and ongoing work. Because as I said, this is a dialogue process. It's not just a dialogue conference. It's a one-off and then you go home. But it's actually a process so that people can stay engaged with each other, because we know it's going to be over time that we are successful at making and working on some of these things.
Excellent. So we never want to leave a place without a quick call to action. 30 seconds. What's our call to action? Both of you can chime in.
Communicate, 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 communicate. Sit down and talk to each other, and not just talk to each other, with each other, with an open ear.
And I would say don't wait for the framework for dialogue to have conversations with your faith leaders. Try to get faith leaders together with people living with HIV, talk about what's going on in your community. You already have some data at your disposal, and take the initiative to start these conversations so that when the toolkit is available to your community, you have some relationships to work from, and we can get started and get the process going with you. So I think that, as Arthur said, that communication is so key, connecting with each other. Thanks so much.
Thank you all for being here. Once again, I'm JM. Thank you to Reverend Michael, servant leader, Arthur.
It's 1 o'clock.
The United Church of Christ, HIV and AIDS Network, and OHMM for this connection. We are out of time, but I hope we'll see you next time. Thank you so much for this engaging conversation, and we'll see you soon.
Bye, everyone.